Once the cancer or the lump appears in the breast, the patient becomes symptomatic and it's not screening anymore. If triple negative breast cancer is one of the very aggressive subtype of breast cancers, and that will spread very fast and will not give you a time to actually detect. What really does not work, so everything is there, which was promoted as cancer screening in terms of blood test specifically. There are certain set of blood tests which really do not work. Nearly 51% of erythropoietic lesion could be harboring squamous cell carcinoma. So this is more dangerous and should not be missed out, and immediately one should consider a biopsy for this.
What is the role of biomarker at screening stage?
Hello, thank you for tuning in. If you want to come back to this video later, just tap on the like button. It will save it to your like videos so it's easier to find. And don't forget to hit on the bell icon to get notified whenever we drop new content. Stay curious, keep learning, and see you on the inside.
So basically, cancer screening and clinical pearls for general physician. This is what I thought. We all know, and I'm sure my audience would be familiar with the current guidelines of cancer screening. But there are certain unique challenges that India faces, and we all understand that India, being a country where there, I mean, it's evolving from the third world scenario to a better economics. So but then cancer is a challenge, a unique challenge, where if you do not catch it early, the mortality is high, as we all understand. So we all know that cancer screening has played an important part in reducing cancer mortality, and important this bunch of data is there in the literature. But the challenges of cancer screening are that screening is all about actually a health checkup of a normal individual, and normal individual should be motivated enough, should have that much of reserve in terms of financial as well as the emotional quotient to actually know that whether he or she could have cancer. So this is important, and so I'll just move forward with this. So talking about the flow of my talk, I would be defining what I'm trying to say, especially about screening. There are certain specific terminologies. I would be addressing them. The unique challenge that India faces is what I just spoke also, and I'll be speaking and touching uh, again that what are the unique challenges, and of course what India has seen all this while. There has been a collaboration of various centers. There is a National Cancer Institute grid, basically, and this Indian cancer grid, is basically something which is important. And earlier we used to hear about various, collaborations in West, but now you have a grid in India as well. And recommendations with emphasis on opportunistic screening. I'll be talking on clinical pearls after each subsite that I will be uh, doing a touch base with. So it's not all the organs that cancer screening is available that we must acknowledge. It's about specific organs. So we'll be knowing more so in the following slides. What really does not work, so everything is there, which was promoted as cancer screening in terms of blood test specifically. So there are certain set of blood tests which really do not work. And then uh, fortunately there are around 5 to 10%, only 5 to 10% cancers, fortunately, which are hereditary linked. So majorly, as we understand, that cancers 40 to 50% are preventable, and that's something that we have in our hand, and that's why screening becomes more important. Because if you screen and you become more aware, and if it's something is there, you actually first of all cut off the insulting agent. For example, smoking. For example, uh, obesity. So you know that you have certain things in hand. So I'll also be then touching on what you do not have in hand, and that's the hereditary testing, how one can actually approach. And fortunately, these are cancers which are few and small, 5 to 10%, which really one cannot determine one's genes, but at least know that these genes are there, and not do any other habits which trigger cancer. So the Indian guidelines basically are evolving. So earlier, for cancer, basically the guidelines, the treatment guidelines or the screening guidelines were a challenge to find, but now you have fortunately these guidelines, and that's possible because all these dots that you see are basically centers where these centers are located, where the cancer centers are situated, and it's nearly 171 organizations which are included, and 150 cancer centers, as well as research institution and patient groups, charities, professional societies which are associated with the National Cancer Institute grid. So this basically the grid or the collaborative network of these organizations or these cancer centers are looking after nearly 60 to 70% of the Indian cancer burden. So that's a very significant number that these network hospitals are attending to. So just defining what basically cancer screening is. And when I say cancer screening, I mean that, it's a secondary prevention. So what's a secondary prevention? It's something that a primary prevention, to start with, we all know that primary prevention is basically not letting the soil getting spoiled. So the seed does not even start sowing. So you do not give the opportunity for the seed to sow. That the soil is such that the seed will not sow, and uh, it is by basically adopting a very healthy lifestyle. As you can see, prevention is better than cure. It's always the basic fundamental. So tobacco control, diet, and it's all about positive lifestyle. So primary prevention is all about positive lifestyle. Now, what is early detection or cancer screening? It is actually hitting the button when the bud is starting from the seed. The bud has started to evolve, and there, if in case you can nip it in the bud, uh, and that's the point where you do the cancer screening. So early detection, and it's not all cancers that can be early detected. It's only a handful of cancers which can be early detected. Nonetheless, these are the ones which are responsible for major cancer burden in India. So if you look at the early detection, what are the cancers? Uh, the cervical cancer, the breast cancer, or the colon cancer, colon GI cancers, and the lung cancer, of course. So there are now screening recommendations coming for all of these. So talking about scope of screening, when can you screen? So uh, the as we understand that cancer is a disease which is basically from our normal tissue. Our normal tissue, if in case it's it goes, there is a mutation, it goes ori, it there is a fault in the replication, then this tissue basically turns invasive. And once it turns invasive, or has those characteristic of carcinogenesis, it has the potential to spread to other organs eventually. So this is what we call as multi-step carcinogenesis. So from one step, another step comes when another set of mutation comes. So it is basically because of the mutations getting accumulated in each step that the next tissue formation occurs. And if the gap between the two steps, there is a good time span between that, then you can actually get opportunity to act upon. So the scope of screening programs exists if there is a gap between the steps of carcinogenesis. So, for example, in pancreatic cancer or cancers like which spread very fast, as in triple negative breast cancer. Triple negative breast cancer is one of the very aggressive subtype of breast cancers, and that will spread very fast and will not give you a time to actually detect how the tissue from normal will turn into precarcinogenic and will turn into eventually carcinogenic. But hormonal positive breast cancer, on the other hand, would give you certain time. Likewise, colon cancer would give you time. It will evolve from polyp to a carcinogenesis. Likewise, CS cervix, there will be a lesion initially, and those lesion, as we will know, will eventually evolve by into from a multi-step hit of a mutation to carcinogenesis, and that's what basically the scope of screening lies there. Because if you can actually get time to detect the early carcinogenesis steps, there is the time to actually check and nip the cancer in the bud. So that's the importance of it. So you can see this particular triangle over here in the ace. So if it's all about the term screening is all about a normal individual. It's all about somebody who is absolutely asymptomatic. So you can see the blue part of the chart or the blue part of the cartoon where the asymptomatic individuals are. Once the cancer or the lump appears in the breast, the patient becomes symptomatic and it's not screening anymore. It is then about treatment of that individual. Screening is all about asymptomatic patient detecting cancer in an asymptomatic individual, and that's the blue shaded area all about. Now, if I detect something in the blue shaded area as an in situ carcinoma, I would be actually detecting a group of cells which might have a potential of going into cancer, might not have a potential of going into cancer, but nonetheless, it might require treatment. It would require rather treatment, and the eventual impact on the mortality will not be there. However, if it's all about a very small, tiny carcinoma, which is not palpable by hand, but it's on the imaging that one can see. And what sort of imaging? Of course, we'll discuss that. Mammogram and ultrasound and MRI, where to do that. We'll all discuss that. So if it's all about, detecting a very small tumor and detecting it so early that it really does not, there is a small impact on the mortality rate if that tumor is left undetected. But if in case you can actually just detect it so early that you can just avoid a peak of avoid the rise of that blue curve, so that the mortality really does not happen. Now, how did can that small tumor cause a death? No, it will not. Once you excise the tumor, it will not. The point is that this tumor has a chance of a recurrence or not. Yes, even small tumors would have a very small chance of recurrence. So, by screening, you can probably, suppress that chance of recurrence. So, let's say if you detect a 5 millimeter by screening, which could, if in case not screened, eventually be detected as a lump at 1.5 centimeter or 2 centimeter, then though it is a stage 1, but that is you further stratify T1C, there is a small chance that such an individual might have a mortality down the line, several years down the line. Uh, though the chance is minuscule, the chance is small, but nonetheless, you could probably, identifying at 5 millimeter such a tumor, you could probably decrease that chance of mortality. So, what are the challenges in screening program and its lead time bias? That is, early detection does not affect the inevitable fatal outcome, but prolongs the apparent survival time. So, you are in such tumors like DCIS, you are not apparently, delaying a mortality or decreasing the mortality, but you are probably, detecting such tumors and treating them because there is a chance of conversion to carcinoma, but you're not impacting on the mortality. Length bias. It's because of the preferential detection of indolent tumors to tumors which are relatively, slow growing, because they have a step carcinogenesis, and the step carcinogenesis takes a very, very long time to go to another step. So probably you are, detecting something which is very, very slow growing, and you will not really make an impact. Overdiagnosis. So sometimes you might detect something which is relatively harmless, a benign thing, and that also is there. Selection bias. Of course, screening means normal population, and if in case a screening program is getting a lot of normal population, one has to think that are these individuals the one in the entire population, the ones who are very educated and educated about their, they're very concerned about their well-being, or is it about not leaving the people or who have certain social inhibitions or are not so empowered with knowledge of screening? So we need to actually empower those who are really not aware. So that is the main thing, and therefore you can eliminate this selection bias. So, Indian scenario for cancer, as we understand this pie chart, it's basically, breast is the topmost, and you can see then the oral cancers, which are tobacco related, and then you have CA cervix, nearly 1.24 lakh, and then lung carcinoma, nearly 70,000, and colorectal cancers, nearly 65,000 patients being diagnosed every year. Now, if you look at the Indian scenario, basically you see that as compared to the rest of the world, and the Indian scenario, basically you have cancers being diagnosed. Breast is being diagnosed as topmost cancer almost all over the world. Likewise in India. But the one thing which is there is that you see that the incidence of cancer is high, though also in Western world, but the mortality proportionally is higher in India. And the reason is because, you get nearly 60% of breast cancer patients in a locally advanced stage, in a stage where the cancer has spread to the lymph nodes, is the primary is large in size. So that's why, breast cancer, the mortality is higher in India. So we'll talk about breast cancer and breast cancer screening programs. So what does the Western world say? Do a mammogram. We all know this. And clinical breast examination is nonetheless very important. So in the Western literature, basically the best screening should be between the age 40 to 49 years. It starts once in 2 years as per the US program. And American Cancer Society recommends starting at the age of 45 and annual thereafter, and 50 to 74 years once in 2 years by US PTF, and American Cancer Society also recommends annual or biennial. Upper age limit is not specified, but a lifespan of more than 10 years should be there once the cancer screening is being adopted. Now there is Indian guidelines. Now the Indian guidelines say that okay, one can go, if there is a good resource, one can actually go for the mammography and the best of the world. But somebody who is actually having certain limited or constrained resource, what does the Indian guideline say? The primary screening methods, that is clinical breast examination, should be done, and that's very important. The clinician is the epicenter of it. The clinician could be gynecologist, could be general physician, could be oncologist, could be the general physician or the gynecologist, as I just mentioned. So uh, these people are the ones who can actually, detect once they are actually trained. They can detect very small lumps, and can actually detect and lower the mortality as well, probably. So definitely there will be a positive outcome over here. So that's what is important, and that I'm sure will bring down the cancer mortality in India. Now, a bit about mammogram, and when we get a mammogram, so we grade it, that how mammogram is graded, and if it's like 4, BIRATS 4, then we have to actually consider for biopsy. So this is what a triple A assessment in a very good resource setting is, that you must have a clinical breast examination, you must have a imaging in form of ultrasound or a mammogram, and then if there is a suspicious lesion, go for the pathology. So a confident diagnosis is made, and then one can actually proceed accordingly, treating the uh, such a situation. But what are the clinical pearls for Indian scenario? I would suggest that clinical breast examination is very important. So routine gynecologist visits, the gynecologist should also encourage a clinical breast examination. And internist who is actually evaluating a patient for other reasons, let's say diabetes or metabolic syndrome or obesity, should also adopt breast examination, clinical breast examination, and that can detect these lesions. So that can actually be an important part. So breast cancer awareness, that is, that early lesion is usually painless, is an important thing. And breast cancer, breast awareness, I would say that self breast examination should also be encouraged by the physician. Talking about cervical cancer. So cervical cancer, as I told, nearly 1.2 lakh patients are being diagnosed, and WHO has made very bold statements. Of course, we all want that this to succeed, the 90-70-90 program. And what is this? It is that 90% of the girls should be fully vaccinated with HPV vaccine by age of 15 years. 70% of women are screened with high performance tests like HPV DNA by 35, and again by 45 years of age. So where are we currently? We are doing just 1% of it. And 90% of women, that is 90, 70, 90, and the last 90 is 90% of the women identified with cervical disease receive treatment. So how is that possible? With if the patients are so many, how will such a big burden be dealt with? So there is a solution what WHO has given, and it is that on a visual acetic acid examination, if in case you see such a lesion, the WHO has recommended that one can actually go through treating this lesion immediately. See and treat should be the strategy adopted. And by doing this, actually one can on the VIA, if such a lesion is seen, a cryotherapy method can be used immediately and treated. Now cryotherapy uh, uh, has certain limitations, that it can treat the ectocervix. So ectocervix lesion can be treated, and of course, there should be no evidence of any infection. There should be no menstrual period. Patient should not be pregnant. So these are certain things that should be taken into account. The lesion should definitely not be into going into the endocervix. That is what is important. Now, the other thing is, if we talk about other methods, in a resource-rich environment, what are the methods? That is, hospitals, third-tier hospitals. Pap smear is one of the most common things that we use. But now, Pap smear is challenging. Pap smear has its challenges. You need to actually interpret. One more thing which has come up is HPV DNA. So if you have, we realize that all the cervical cancer, somewhere HPV is involved. So HPV is the virus, and if in case the HPV DNA is positive, then the threshold of suspicion should go high. One must triage such an individual by doing cytology, direct colposcopy, VIA. So it becomes more scientific and more, very more specific for such a situation. Now, HPV DNA can be positive, but you can still have a negative, a normal individual. So, of course, this requires that one must either, if in case one is checking HPV DNA in a rural population, let's say in a cluster, then one can actually do the VIA methodology. One can also do the direct colposcopy if in case it's a resource rich environment or a tertiary hospital. One can go for the cytology. So basically the challenges, as I said, that with the pap smear, pelvic examination is a problem, and then pap smear you require frequent visits. One visit is for actually collecting the smear, and then the second visit for collecting the report. And of course, then the report is positive, then you need to try first colposcopy. So how to cut down these visits basically is also something which is important. So there is this particular device which was there, and the gentleman, as you can see, Mr. Palit, actually, he was also there in the Shark Tank, the famous program that comes on television these days. So he was promoting his product, the Cervicheck, and this basically product could turn out to be a boon. And here it can actually detect the HPV DNA, and if the DNA is positive, such a situation, the individual can be triaged up towards going for a VIA or a cryotherapy straight away. So such a product enables the individual. So it's something like a pregnancy check kit. So as the women can check pregnancy by themselves, this Cervicheck is a kit which enables the women to check whether they have HPV DNA positive by themselves. They do not need to go to the doctor. So this product could actually help them. If it is positive, Cervicheck is positive, then they can actually visit the doctor and then get a VIA or get a better examination or a pap smear done. So HPV DNA testing, this was checked by ASHA workers, in Osmanabad district of Maharashtra, and it showed that such a strategy, that one round of HPV testing was done between 30 to 59 years of ladies, and there was a significant reduction in the number of advanced cervical cancer by nearly 50% compared to the standard of care, whatever practice they were following. So that's really enormous. So this pathway can be adopted, that you check the HPV DNA, and if it is positive, you can, depending on your resource setting, go for a visual acetic acid examination by the ASHA workers, and if it is positive, one can actually consider seeing and treating. So I just showed you that if in case VIA is positive, and if you have a lesion like this, you can straight away go for a cryoprobe, provided that one has a fair idea that this is not going into the endocervix. So this could be done. So what about other cancers? Talking about oral cancers, and this is predominantly in the males, and certain females also who have gutka chewing or tobacco chewing as a habit in certain parts of country. So oral cancers, this is again one of the simplest screening. One just have to peep in the mouth, and if in case there are certain lesions like this one being seen, so you can see the curdy white lesion along the lateral aspect of the tongue. And if you can identify this, this is nothing but oral hairy leukoplakia. And the rate of progression to malignancy, it's reported between 3% to 17% yearly. So such a lesion should be again addressed by biopsy, and by abstinence of tobacco should immediately be advocated. And but there are various treatments, and along with antioxidant treatments with it. Now this lesion, the second lesion, is more sinister, because that has a tendency to, leukoplakia has a tendency to progress to malignancy, but this one is nothing but erythroplakia. And nearly 51% of erythroplakic lesion could be harboring squamous cell carcinoma. So this is more dangerous and should not be missed out, and immediately one should consider a biopsy for this. So what are the clinical pearls in oral cancer screening? As it is that, do check for oral hygiene and examination in your patients who were having a history of tobacco chewers or smokers. Have a good look on the buccal mucosa, inside the cheek, both sides, as well as below the tongue, along the lateral aspect of the tongue, and that could give you a good idea. That also, a sharp tooth can also cause repeated cuts. So encourage the individual to undergo a dental blunting, contact your dental colleagues, and you could probably save a patient from developing cancer, and a person from developing cancer. So that's important. So GI cancers, one of the most important cancers, which actually can be screened again by gastroenterologist and by doing a colonoscopy, or there are other methods also. So colorectal cancers are important from that perspective, again, because you have step carcinogenesis. As you can see, it's basically the evolution of an adenoma to a late adenoma and eventually a carcinoma, and multiple mutations happening over there, which actually lead to this. So as we understand that most of the cancers of colon, nearly 2/3, 70%, are left-sided colon cancers. So just a sigmoidoscopy and a barium enema contrast colonogram once in 5 years may suffice. Now, we all know sigmoidoscopy is a OPD-based procedure. It does not really require admission, and sigmoidoscopy can be done easily. So, if a sigmoidoscopy is only done, and you can also give a barium enema contrast once in 5 years, you will be actually ruling out a lot of colon cancers. But nonetheless, what are the actual recommendations? So, the actual recommendations are that, in an average risk patient, there is no high risk. Then in such an individual, one must actually have a fecal occult blood testing done. So at least 3 samples should be given at of the subsequent defecations, and 3 samples, 2 from each sample. 3 consecutive stools should be examined without rehydration, and this is the best thing one can do in a limited resource setting. For a flexible sigmoidoscopy, if that opportunity is there, one must go for it. It is good for opportunistic screening. A fecal occult blood and flexible sigmoidoscopy once in 5 years can be done, and will catch a lot of these malignancies if in case they are shaping up. Colonoscopy is actually once in 10 years, and for somebody who has some real problems with colonoscopy, then at least a double contrast barium enema one can actually consider in 5 years, although this is not the actual way. A colonoscopy is definitely the gold standard. This is how a CT colonogram looks like. So CT colonogram, the imaging is catching up, getting better, but still not there. You can catch such a polyp over there in the CT, but you still have to go and remove it and address and find out what it is actually. So colonoscopy is important. So fecal occult blood testing and sigmoidoscopy, basically, in case we focus on these 2 things, these are entirely OPD basis procedures, and they are doable on an OPD basis. Once in 5 years is good enough after the age of 50. And especially somebody who is having iron deficiency anemia after the age of 50, please consider doing a fecal occult blood testing and sigmoidoscopy and ruling out colon cancer. It's so important. Iron deficiency anemia, microcytic anemia after the age of 50, please do check the GI tract. So talking about the other cancer, which is a new entrant, and this is lung cancer, which is now it's being realized that yes, we have the tools to actually screen such a cancer and nip in the bud and get the needful results. And this one story is a very good success story, because this is one cancer which has a very high mortality, and definitely treating such a cancer or identifying such a cancer at a very early stage, the screening program should be encouraged. So the first trial, the clinical trial which actually spoke about this, was from US, and this was a group of centers where they actually did a low dose CT scan versus a chest radiograph, and they found that with as compared to the chest radiograph, you can actually go ahead and the low dose CT scan can reduce the cancer mortality by nearly 20%. 6.7% reduction in all cause mortality with low dose CT scan was found. So that's 20% is a good number over there compared to a chest radiogram. And there was another trial in Europe, and there they actually took similar number of patients, and you could see that similar reduction in numbers. So the numbers over here, overall reduction was nearly 26% at 10 years. So definitely two big trials with a lot of normal individuals, 15,000 in Nelson and nearly 20,000 in NLST, showed that you have the potential to catch lung cancer early and treat them well, and you can then bring down the mortality. So is everybody eligible? No, everybody is not eligible. It is the high risk category, and Nelson trial actually they took 50 years and above individual. NLST had taken 55. And from 50 years to up to 80 years, they had made the individuals eligible. Now, one thing is important, that anybody undergoing a lung cancer screening should have at least a survival. Otherwise, because of other comorbids, should not be so overwhelming, and the survival should at least be 10 years. Should have a lifespan of 10 years remaining. It should not be a heavily a patient who is on dialysis, or somebody CKD or bad diabetes, that should be considered for such a lung cancer screening program. So somebody who is having an age of 50 years and above, and the age limit over there was 80 years, and having a heavy smoking history, that is 20 pack years. Now there are now discussions coming up that somebody having a family history of lung cancer should also be strongly considered. So that's something which is important. So somebody who is either a current smoker but is ready to quit, or has quit within 15 years, and other minor criteria and considerations are taken into account. So basically this was taken, and then after educating the individual that look, there could be a lesion which could be detected, and if a lesion is detected, we would have to go and biopsy it. So this all has to be done. So now every screening program should have a counseling that if in case a cancer is detected, you would require treatment. It should not be that it should be left dangling. The situation should be that the individual goes to the healthcare system, gets himself diagnosed with cancer, and really does not know what will happen next to him. So every screening program should have the component of educating the individual that look, if in case you are diagnosed or you are found to have a problem, then you will be given this particular situation solution. So this is what it is. So this is where lung cancer screening was, and low dose CT scan definitely has a good role. And basically, at least once a year, low dose CT scan, if they are done, and one can actually then detect lung cancers in a very early stage. So this is how they are being advocated. Are there any blood tests which can help in cancer screening? So the conventional blood test, which we all know, the PSA, CA 125, CA 19.9, people have used them. Certain labs have advocated for them that one can find cancer by looking at these. And sometimes I get individuals who come with reports from their annual health checkups, and that those annual health checkups are mandated by the insurance agencies, and they give a battery of tests. Amongst those tests are these tests as well. And unfortunately, again, I said, without any counseling, without any clinical corroboration, one might actually end up creating a lot of anxiety, and nothing would come out. So these tests basically, except if I talk about the PSA and the CA 125, the rest of these are not leading to you anywhere if in case it's a asymptomatic individual. Even in CA 125, individual is asymptomatic. Ovarian cancer cannot be very well screen detected. Even there is no formal screening program to detect ovarian cancer, but we do get people who come with reports of raised CA 125, and then ask, well, all this could be because of variety of reasons like peritoneum inflammation. So CA 125 could be raised over there. Now, talking about PSA specifically, so PSA, of course, there was into a category of prostate cancer screening test. It is still there, but again, this should be more of a communicative screening program, more of an opportunistic screening program, and not, it should not be a public screening tool. So basically, more of a opportunistic, more of a dialogue is required by the clinician and the individual undergoing a PSA, because there, again, a biopsy would be required. Prostate biopsy will be required if PSA is high. And again, certain things need to be ruled out, that you have to have no infection, no UTI while before you getting the PSA done. And certain PSA rise could be attributable to age as well. And beyond that, basically one will have to undergo MRI of the prostate and then do a biopsy. Talking about certain cancers where we really do not have much of a control, and that is basically family history of cancer is there, and then we find that that individual is probably, sometimes we get people who ask that their elders did have a family history of cancer, what to do. So basically, the best scenario is that the index patient, the patient who has cancer, he gets himself screened by a blood test or by buccal mucosa swab for genetic cancers. So let's say, for example, there is a lady who is diagnosed with breast cancer, and she gets a blood test done to see whether it was because of any hereditary this thing. And then if there is a gene identified, then that gene can be searched in the siblings as well as the progeny of that particular patient. However, if in case the patient is not there, and the children come at the age, let's say, the children should be mature enough to understand. Most of the times, I say that these people should be above the age of postgraduate years, nearly above the age of 24 years, mentally mature to take the diagnosis if in case it comes positive. So they should be most likely financially independent as well. So then they can actually undergo such testing. And once they undergo such testing, then one can actually see what sort of gene comes out, and then there could be surgeries, prophylactic surgeries involved, and then there could be prophylactic medications. But largely, there could be screening programs which could be offered in terms of regular imaging. And one of the most important things and underrated, it is that these individuals should be emphasized that please do not go into any sort of addictions, tobacco or alcohol, and there should be strict abstinence, and a very positive lifestyle should be adopted right from the young adulthood, so that you can actually mitigate the chance of this second hit. Because as per the hypothesis of Knudsen, you need a second hit most of the times to actually get the carcinogenesis done. So there is a very high chance that this could happen, but smoking or alcohol could accelerate that. So with these basically things, I would just sum up and say that these were cancer screening tests and cancer screening protocols. So there are certain things that one should be careful about cancer, and these are called the red flag signs. And any change or any disturbances in these basically should be immediately reported, and the individual should immediately report, and the physician should carry out certain tests to rule out cancer. So, nonetheless, one might it's not exactly a screening program, but it is at least detecting cancer at a relatively early stage. So, what are these? And these are change in bowel or bladder habits. So, after the age of 50 years, if an individual has a change in bladder or bowel habits and he hasn't undergone a sigmoidoscopy before or a colonoscopy before, please encourage to do so. You could encourage for a fecal occult blood testing and sigmoidoscopy once in 5 years, or you could encourage colonoscopy once in 10 years. So that could be done. For bladder habits, again, bladder habits in male, one should think about prostate and should discuss, as I told, a good prostate examination, urine routine microscopy should be done, and then probably a multiparametric MRI might be required if in case there is a risen PSA, and then accordingly a biopsy is planned. A sore that does not heal, so something in the mouth which is not healing, repeated tongue bites or tobacco chewer. So just be on guard. You peep inside and you find a complaint that this is not healing, then requires a biopsy. One cannot leave it at that. And unusual bleeding or discharge. So any of the orifices in the human body, if there is unusual bleeding or discharge, especially postmenopausal bleeding, is something one should actually pay attention to, because these cancers, like uterine cancers, could be there, and they could be caught at a relatively early stage if in case a postmenopausal bleeding is reported early. Thickening of lump or breast elsewhere. So again, this is a very common thing that we advocate for ladies, that please go for checkup immediately. And indigestion or difficulty in swallowing. So indigestion is something that people start taking pantoprazole and PPIs. They take it regularly for almost several months together, but they do not get an endoscopy done. So please, if in case the GP finds that a 2 week, more than 2 week, 3 week use of pantoprazole is there, encourage for endoscopy. Obvious change in wart or mole, nagging cough or hoarseness. So any chronic cough, of course, tuberculosis is one of the most important thing that has to be kept in mind. Nonetheless, cancer is also catching up actually in terms of the incidence. So please keep cancer in mind, and also do not start the ATT without considering a biopsy. So unexplained anemia, fever. So again, one has to look for the causes of anemia, and one should not think it's always nutrient deficiency. And sudden unexplained weight loss, which is not being explained by dietary modifications, exercises. So this should be looked into, and one must do the needful checks. So with this, I hand over to the organizers, and we can actually take questions.
Thank you, sir, for the very enlightening talk. We do have some doubts coming in from our doctors, and we will be getting into that. So I'm taking one of the earlier questions that we had. So the question is displayed on the screen. Dr. Narendra Singh asked, which type of cancer will be high risk for death?
So there are several cancers which would be high risk for death. I mean, it's like there are cancers which would spread very fast, as I mentioned, triple negative breast cancer. So even in the organ subtypes, we have now various uh, molecularly different cancers. As I took the example of breast cancer, I gave the example that if the cancer is triple negative breast cancer, so such a cancer is more aggressive in subtype. Likewise, if in case I talk about brain tumors, glioblastoma multiforme is the grade 4 glioma, or the grade 4 tumor of the brain, which has a tendency, propensity to spread very fast, and has, again, subdivisions. So there are now, as science is evolving, we are trying to understand such bad tumors more precisely. Are all these bad tumors, all of them are so bad, or there are certain subsets which might do better in them? For example, I will take the example of brain tumor, glioblastoma multiforme. Earlier, 10 years earlier, we had this information, okay, GBM means that the average survival is somewhere between 18 months to 2 years. Now, there were certain set of patients who were actually not doing so well within a year. There were a certain set of patients who were actually going much, much beyond 3 years, 4 years as well. So we are now realizing that there are certain mutations and there are certain group of changes in such tumors that make them better ones, and then there are certain changes which make them the worst ones. So basically, each tumor has a lot of variations, and that is what identifying these variations, and if in case you have a solution to these variations, you can use them. For example, HER2 breast cancer is a very aggressive tumor, very, very aggressive tumor. Somebody who was diagnosed with HER2 breast cancer, ERPR negative and a HER2 breast cancer, used to have a dismal survival. The survival used to be less than 5-year survival was absolutely abysmal. If it's locally advanced, let's say a stage 2 3, such an individual would not make it beyond 5 years. But with the availability of targeted therapies, realizing that there is a protein which is actually causing the tumor to grow very fast, we have now a medicine like trastuzumab which can actually make the outcome better for such aggressive cancers also. So it is all about knowing the cancers in depth, in their proteins, and then eventually you realize that these are poor prognostic ones. So there, to broadly answer, there are certain cancers like I just mentioned, that triple negative breast cancer for the breast, small cell lung carcinomas. These are certain types which will be at a higher risk for death. Mucosal melanomas, which are metastatic. So these are the ones. And poor risk acute myeloid leukemias in adults. And the cancers which are actually happening above the age of 80 years, there is a high chance, because of the comorbidities and the confounding factors, which can increase the death.
So moving on to the next question, Dr. Kulkarni asks, what are the earliest symptoms and clinical signs of ovarian cancer in elderly age group? Is it usually diagnosed in advanced stages only?
Yes, Dr. Kulkarni. Most of the times, unfortunately, ovarian cancer is diagnosed when basically the lady starts feeling some bloating, some indigestion, uh, distension of abdomen, dyspepsia. These all symptoms. The pedal edema, that is leg swelling. There could be basically breathing difficulty because of pleural effusion. So unfortunately, abdomen is one space where detecting very small tumors becomes difficult. And unfortunately, the CA125 and transvaginal ultrasound study, what the UK, there was a big trial, uh, turned out that ovarian cancer screening really did not make an impact. But in certain high risk individuals, like those who are genetically prone, like BRCA positive disease patterns, one can actually consider doing a annual TVUS and CA125. Somebody who's having a family history of ovarian cancer, such the siblings of such an individual or the children of such an individual after the age of 10 years prior to the individual was diagnosed with cancer, they could probably start screening themselves with transvaginal ultrasound and CA125 annually, and could probably detect earlier. There, this could make an impact. Otherwise, mass screening, it is not making an impact, and these are the symptoms.
Next from Dr. Nair, what are the signs of lung cancer in chronic smokers?
In chronic smokers, there could be aggravation of cough. So usually they will have some chronic bronchitis in the which gets aggravated in winters. But if in case it's the aggravation of the COPD, which is happening very frequently, or if it is like cough which is lasting long and hemoptysis associated with it. So aggravation of the cough. So there is some cough, but the cough gets aggravated. That is one particular sign. And apart from that, of course, weight loss and you could have some neck swelling. The individual could present with that. Some pain in the shoulder, especially in the pancreas sort of scenario. And lung cancer again would present in an advanced stage when the individual is diagnosed. Individual could be symptomatic with a heavy burden of lung cancer, the facial puffiness. So all this could be there, and an immediate, chest imaging should be considered. So for chronic smokers, that's what I said, that low dose CT scan. First of all, promote abstinence of tobacco. Low dose CT scan annually after the age of 50 years should be encouraged. Of course, this one should be, abstinence of tobacco. They should be ready for, and make sure that you might end up doing a biopsy. So if all these three things are there, please go ahead and do a low dose CT scan annually.
Next question from Dr. Manishwari. What are the percentage of cases misdiagnosed in clinical practice for early detection of cancers?
So percentage of case misdiagnosed in clinical practice, well, it's very difficult to answer that because this is something which audit can answer. So this is something which I may not be able to particularly tell, but I think so with the proper protocol being followed, the algorithm being followed, the checklist being there, I think so the chances that you miss, cancer where there is a screening program, a center, institute which is having a screening program, the miss would be very small, I believe, because these institutes or centers would be very well prepared with it, and so the miss is going to be very small. Of course, talking about mass going into the masses, as I spoke about Osmanabad rural district in Maharashtra. So again, there you need to train your primary healthcare workers very well and make sure that a good triaging system exists. That is, the patient is moved to the next level towards a better healthcare facility if in case there is a positive catch, like a VIA getting positive. So there must be a triaging system for call or doing the next thing.
So the next question from Dr. Madhav. What is the role of biomarker at screening stage?
So biomarker, basically anything which actually can be repeated, any test which can be repeated and consistently could give reasonable answers to a specific question is a biomarker. And of course, biomarker could be a blood biomarker. It could be a radiological biomarker like a CT scan. So if in case the question pertains to a blood biomarker, unfortunately, we are still evolving in terms of blood biomarkers. We are still not there in terms of robust blood biomarkers screening in mass population. Yes, we have answers, good answers in high risk individual who are wanting answers for genetic screening. So like tests like BRCA1 and 2, we have some good answers for high risk individuals, and such an individual should undergo cancer screening. Yes.
So next, Dr. Gupta asks, what about the screening for prostate cancer?
As I mentioned that Dr. Gupta, prostate cancer screening should be after a discussion or opportunistic screening. It should be basically after a discussion and the patient understanding, the individual understanding that yes, there could be a biopsy involved, yes, he could have to undergo a multiparametric MRI. It should not be that the after a high PSA, let's say a PSA of 12 with the urine routine microscopy normal, it should not be that the patient is not willing for testing further. So a proper parectal examination should be done after a PSA has been checked. After a parectal examination is done, prostate is filled, uh, and if there is a suspicion, even if there is no suspicion, the individual should be encouraged for a multiparametric MRI and then guided biopsy. So there is no doubt about that it should be a opportunistic screening, because mass screening for prostate cancers have really not yielded those results.
So next, Dr. Jyoti asks, any hereditary influence for NHL in offsprings, both parents at different variants? If yes, how to start screening and at what age?
Unfortunately, we do not have an answer to the latter part of the question, that we really do not have, uh, a proper screening guideline. But yes, for CLL, basically chronic lymphoid leukemia or follicular lymphomas, so there is now realization, yes, that can actually happen in siblings and close individuals, or they could be genetically inherited. To how to start screening? Well, I would say that let's say the index case is diagnosed at the age of 70 years. The screening should always start at least 10 to 15 years prior in the individual who wants to screen himself. So the other individual should start, let's say, at 55 years of age. So that should be, how one can go about it. So diagnosing, such cancers, the peripheral smear examination is good enough, and that could be carried out once on an annual year basis.
Dr. Anjali asks, so could you shed light on tongue papilloma also? Patient is 80 years old with thick, glistening, sticky secretion. Whether surgical resection is must or any other management is also possible.
It's very difficult for me to actually talk about a specific case over here, so I would request that I would rather leave it to the clinical acumen of the clinician who is actually seeing the case.
So next, Dr. Agarwal asks, how popular is genetic testing in India and what is the cost like?
Well, genetic testing in India is being realized as a genetic cancers are being realized as an important thing, that they also exist, and people do get worried in if there is a genetic cancer in the family, and they have now started asking that can I get that cancer? So yes, I would not say the term popular, but yes, the awareness is growing, and more so in metropolitan cities as well as second tier cities. People have started asking, not just second tier cities. I would say that even rural India, the question would be there. I mean, it's pretty common thing that one would get affected, two, three cancers in the family gets really concerned that something's really going wrong. So yes, the genetic testing is a question which comes to one's mind if in case these sort of incidences start happening in the family, that the sister is affected and then the brother is affected, then what are my probabilities? Even a rustic individual would ask. So the cost, well, it again depends what are you looking at, what do you want to look at, and also the lab where you want to send. I would say that most of these tests, the genetic test would somewhere cost somewhere around 20,000 to 30,000. But more important than the cost, I think so, is the fact that the connect to the physician or the oncologist, who can actually explain them what is in store. What do you anticipate? These people are very anxious, and therefore, I think so. The more important question, Dr. Agarwal, is that what is basically that how can the anxiety be allayed, and what is the solution that the oncologist can give in terms of after detecting, then what? So those questions should be navigated by the physician or the doctor, and a good pre-test counseling should be done. So that's what, if I could have answered your question that way.
So, sir, there's still a lot of questions that are coming in. Just like to take your permission if we could take a few more.
Yes, please.
Next is from Dr. Mohammed. Any precautions after fully resolved case of gastric DLBCL?
So after a case of gastric DLPCL fully resolved, we usually follow up with regular scans, and we follow it up for a maximum of 3 to 5 years, depending on the institute's protocol. So we do regular abdominal scans, CT, and of course, depending on the disease. So it's a CT chest and abdomen most of the times, which is done once in 6 months, and endoscopy might be required. So that's what it is. It goes to a span of 3 to 5 years, and then we actually follow up. Regular testing of the cardiac is done if in case anthracyclines were used or adriamycin was used at some point of time. Yeah.
So the next is Dr. Sabia. How common is stomach cancer caused by H. pylori?
It's a very common thing. H. pylori does, it is understood now that H. pylori does lead to stomach cancer carcinogenesis, but it's not always that by treating H. pylori infection, you might actually get reduce the chance of carcinogenesis drastically. Population eradication of H. pylori is not really the way forward. That has not been found. Those studies done in small cohorts have not been successful, unfortunately. But yes, stomach cancer is caused by H. pylori infection. I would say that, I mean, difficult to state that how, what would be the percentage, but I think so somewhere in the tune of 40 to 50% could be the answer.
Dr. Purohit
Especially
asked,
the
what is the role
especially
of
the antral cancers, the distal cancers which are found. Antral cancers are caused by H. pylori.
So Dr. Purohit says, is there any role of acetic acid test in cervical
Yes,
cancer?
I did mention visual inspection of acetic acid, VIA. So that's what was about the example I gave about Osmanabad district and how they did, actually the primary ASHA healthcare workers, they did the VIA testing and they could triage the patients accordingly and bring down the cervical cancer risk. Yes, it's a very important tool. And VIA testing, actually, visual inspection of acetic acid examination, one can actually then uh, treat also by cryotherapy, especially if it's a ectocervix lesion, then one can actually get the results also.
Dr. Navin says, oral ulcer occurring frequently after healing but not progressing in size can be a reason for oral cancer.
So size might not be the thing, and any non-healing oral ulcer needs to be addressed by a biopsy,
So doctor is
especially
taking,
yeah.
yeah. So doctor is taking the last two questions for tonight. Dr. Ghanshyam asks, after radiotherapy for oral cancer, frequently white spots emerging in oral mucosa, will they convert into recurrence of SSC?
So depending on what these white spots were, whether these white spots had been before, were these a part of leukoplakia prior, or if in this case it's post radiotherapy, then it could be because of mucosal injury, and it will eventually heal. So they might not be, something. But yes, if in case your question pertains to uh, that because of tobacco chewing or smoke intake or alcohol consumption, there has been the entire field of the buccal mucosa has been exposed to toxins, and only one part was actually addressed. Let's say the right side buccal mucosa was only addressed, but the left side buccal mucosa was also exposed to toxins, and in the future course of time can have a tendency to turn into cancer, because it could have those changes, those precancerous mutations, changes which over time can turn into cancer. So yes, it can turn into cancer, but then It's not because of radiation that it will turn into cancer, but because the radiation would have been addressed to the involved field only, and not the entire this thing. There has been a thought process of actually giving radiation to the whole area, which has a tendency to develop recurrent field cancers. This is called field cancerization because the entire mucosa is prone to mutations. So, but then these white spots, which if you're talking about the mucositis part, they will heal and they are not going to cause cancer.
So, doctors, taking in the last question for tonight. That's from Dr. Krishna Priya. Cancer check running in family, is tumor marker available?
So, cancer cheek running in the family, again, we need to check that whether it's because of any tobacco insult. If it's not because of tobacco insult, then actually we can look into whether there is a possibility of a Lee-Fromany syndrome, which could be there. Lee-Fromany is a P53 deletion, homozygous deletion, which could happen, and this can cause squamous cell carcinoma in any part of the body, or carcinomas in any part of the body, and also squamous cell carcinomas are one of them. So here I would say that one has to take care of the buccal mucosa by abstaining again from very spicy food, very food which can cause ulcers, and also food habits which can cause cancer, food or tobacco consumption or alcohol consumption which can cause cancer. So one has to be careful about this, and keep a good dental hygiene, immediately address a sharp tooth. So these all scenarios can actually help. There could be a small role of antioxidants to play, but the scientific data behind it is not so robust. I would say that a positive lifestyle could actually make a difference.
So with that, thank you so much for taking in so many questions from our doctors very patiently. Thank you once again for this wonderful session, sir. It was very helpful for our doctors, and it was lovely to have you here on Netflix with us, and really hope to see you again. Thank you so much once again, sir.